স্টুডেন্ট কি আছে অনলাইন? Hmm? Dear students, Assalamu alaikum. This is Dr. Syed Alamgir Safar, Professor, Department of Gastroenterology. Hope all of you are keeping well, staying safe with your family in your house. But here we are missing you a lot because you are the heart of the campus of Jalalabad Ragib-Rabeya Medical College. Your absence seems, the campus seems so empty without you over here. Even this is better. After quite a long time, we could communicate with you over this internet. Today we are going to discuss chronic liver disease. Uh, Chronic liver disease we have already discussed in your lecture class, but in lecture class we covered the theoretical aspect of chronic liver disease. So today I have decided not to go in detail in theoretical aspect. Rather, I will discuss about the practical side of chronic liver disease. Suppose how the patient will come to you, how will examine the patient, what are the findings that you will get, and how will you manage the patient. So this will be the point of emphasis in today's class. Before entering into the chronic liver disease, I want to mention that hepatitis can be acute, can be subacute, and can be chronic. If the duration is up to 8 weeks, we used to say this is acute hepatitis. If it is from 8 weeks to 6 months, then it is subacute hepatitis. And if it is more than 6 months or more than 6 months, that it is chronic hepatitis. And this the chronic hepatitis leads to chronic liver disease and ultimately to cirrhosis of liver. Let's have a look on what are the viruses that are involved in a case of hepatitis. There are some are common, some are less common, and some are rare viruses. The common viruses are hepatitis A, B, E, hepatitis D with the help of hepatitis B, and hepatitis C. And the less common viruses are cytomegalovirus and Epstein-Barr virus. And some rare viruses are herpes simplex virus and yellow fever virus. Among these, hepatitis A, B, and E cause acute hepatitis, whereas hepatitis B, E, and D cause chronic hepatitis. So hepatitis A and hepatitis E are not causing chronic hepatitis. They are causing acute hepatitis, whereas hepatitis B can cause both acute hepatitis and chronic hepatitis. Hepatitis A is more in children, and hepatitis E is more in adults. Hepatitis B is common in both groups, adults and children. Hepatitis A and hepatitis E are spread by fecal-oral route. So they are spreading with food and water. Whereas hepatitis B, C, and D are spread with body fluids and blood. Suppose a blood is transfused to a patient without proper screening, can transfuse, can cause infection of hepatitis B or C. Or we are going to saloon using the blades of saloon to shave. There, the person may get hepatitis B or C infection. So it is these viruses spread by blood and body fluids. Just have a look in the picture. Here is a picture of a normal liver and a cirrhotic liver. So what should we say about what is liver cirrhosis? So if there is diffuse fibrosis of liver together with nodule formation, it is called cirrhosis. Here you see the normal liver is a smooth surface and the cirrhotic liver has so many nodules on its surface. If you think about the causes of cirrhosis in a developing country like Bangladesh, the commonest cause is chronic viral hepatitis, and most common one is hepatitis B, and the other one is hepatitis C. But in Western countries, they could control the spread of infection much. Moreover, they are habituated with alcohol intake. So alcoholism is the commonest cause in Western country. The third cause, non-alcoholic steatohepatitis, and this is an alarming one because only due to food habit a person is going to develop cirrhosis of liver. All over the world nowadays, people are very much interested for fatty foods. They are taking lot of fast food, lot of mayonnaise, cheese, etc., etc. But they are not doing physical exercise. So the liver is becoming fatty, and ultimately, this fatty liver is giving rise to cirrhosis of liver. The fourth cause is autoimmune hepatitis. And the next one is there are some genetic causes like hemochromatosis due to iron overload, Wilson's disease due to copper overload, and alpha 1 antitrypsin deficiency. And there are also some drugs and toxins. You know better. In our lecture class, we also discussed few other causes of cirrhosis of liver, but here I have emphasized only on the common causes of cirrhosis of liver. Now, what are the clinical features that you will search for in a patient of chronic liver disease or cirrhosis of liver? The first one is jaundice. Yes, jaundice, because the patient of chronic liver disease, uh, there is malfunction in the hepatocyte. So hepatocyte cannot uh, shift the bilirubin from the blood to the bile. So the bilirubin level in the blood increases. So patient develops jaundice. So jaundice is the first symptom. And the other things, hand examination of hand is very important to diagnose a case of chronic liver disease because there are a lot of signs and symptoms in hands in chronic liver disease. Especially 7 signs and symptoms are very common, like palmar erythema. If you check the palm of a patient of chronic liver disease, you will find that the redness at the thinner and hypothinner area as well as at the palm of the fingers. So palmar erythema, redness at the palmar aspect of the hand is a common feature of chronic liver disease. The next one is Dupuytren's contracture. Yes, due to fibrosis and shortening of the superficial palmar fascia, uh, there is contraction or flexion of the metacarpophalangeal joint and proximal interphalangeal joint. So the most affected fingers are the ring finger as well as the little finger. And the commonest cause is alcoholic cirrhosis. So in alcoholic cirrhosis, there is thickening and shortening of the superficial palmar fascia, causing contraction of the metacarpophalangeal joint and interphalangeal joint, mostly at the ring finger and little finger, and this is known as Dupuytren's contracture. The next one is aesthetic 6 or flapping tumor. When you will ask your patient to extend the elbow joints and dorsiflex the wrist joint and keeping the fingers apart from each other and observe the patient. If the patient has hepatic encephalopathy, that is impaired cerebral function due to hepatic cause, you will find flapping tremor. That is irregular and jerky flexion and extension movement of the wrist joint, and it is known as flapping tremor because it resembles the bird flapping its wings. So it is known as flapping tremor. Flapping tremor signifies that the patient has developed hepatic encephalopathy. Next is leukonychia. Leukonychia, if the patient has leukonychia and you examine the hand of the patient, you will find that the nail bed of the patient has become white. It is a feature of hypoalbuminemia in chronic liver disease. The fifth feature of hand is the clubbing. Here in the picture, you can see that the fingers has become like that of drumstick. The tip of the fingers are widened. There is bulbar enlargement of the tip of the fingers. Signifies that this patient has got clubbing. It is another feature of chronic liver disease. This is very important word, spider nevi. Is look at the dorsum of this patient. There are so many red, small red patches. Spider nevi, actually, if you see the magnified view at the lower picture, there is a central arteriole with radiating capillaries, and one or two spider nevi can be present normally in normal individual, but more than two spider nevi is pathological and signifies chronic liver disease. Spider nevi normally you will get in the area of superior vena cava. You will get it at the dorsum of the hand, you will get at the face, neck, and the upper chest above the nipple line. These are the sites of spider nevi, and when you will get more than two spider nevi, it will suggest that the patient has got chronic liver disease. And the last and the seventh uh, hand feature of chronic liver disease is muscle wasting. Look at the picture. There is thinning of the thinner and hypothinner muscles of this patient, and this is due to chronic liver disease. So if you summarize now, what are the hand findings of cirrhosis of liver? You will find that there is palmar erythema, dupuytren's contracture, flapping tumor or asterixis, leukocytia, clubbing, spider nevi, and muscle wasting. So it is so much important to examine the hand whenever you suspect a patient that he has got chronic liver disease, because so many signs are lying over there. Now, examine the chest. When you examine the chest, you will find that in case of male, there is loss of male type of hair, no male type of hair, and you will get spider nevi as well over here. The third one is gynecomastia. So all these things actually happening due to increased level of estrogen in the blood. Normally, a normal liver detoxifies or neutralizes the estrogen in the blood. But in case of chronic liver disease, the diseased liver cannot neutralize the estrogen. So estrogen level gradually rises in the blood even in male person. And this estrogen causes loss of male type of hair distribution as well as gynecomastia in male person. Now, if you examine the abdomen of the patient, look at the abdomen inspection, and you'll find that there are some engorged vein in the abdominal wall. Engorged vein. These are the collaterals. This has developed due to portal hypertension. There is rise in portal pressure in the portal vessels, so they have developed collaterals to pass the blood to the systemic circulation. These collaterals are most common near the umbilicus. Sometimes they radiate from the umbilicus. In that case, it is known as caput medusae. And what is the direction of blood flow? It is always away from the umbilicus in case of cirrhosis of liver. Then when you examine the abdomen, you will find that there is distended abdomen. Many a time, the patients of chronic liver disease seek treatment for abdominal distension. And when you examine the abdomen, you will find that the abdomen is distended, the flanks are full, the umbilicus is centrally placed, and if you percuss, you will find that there is shifting dullness. And a patient like this one who has huge ascites, you will also get the fluid thrill. So this will suggest that this patient has got ascites. Then when you try to palpate the abdomen, you will find that there is spleen, palpable spleen sometimes, because there is splenomegaly in chronic liver disease. So the spleen, if it is enlarged for more than 3 times, then you will be able to palpate it. So there is splenomegaly. Then what about liver? Yes, when you will try to palpate the liver, in most of the time you will not be able to palpate the liver, because in chronic liver disease or cirrhosis of liver, due to inflammation and fibrosis for prolonged period, the liver becomes shrunken. It becomes smaller in size. So it is not possible to palpate a shrunken liver. So for you should remember this one, that in chronic liver disease, liver is shrunken and smaller, so it is not palpable. But it has got some exceptions. Yes, there are some exceptions, like if it is due to alcoholic cirrhosis, the liver will be enlarged and you will be able to palpate. if it is due to hemochromatosis or if it is due to primary biliary cirrhosis, then the liver becomes enlarged rather than become shrunken. After examining the abdomen, in case of male, you have to palpate the testicles of the patient because you will find testicular atrophy over there. Now, you will get some hemorrhagic tendency, features of hemorrhagic tendency in a patient of chronic liver disease, because in chronic liver disease the platelet count is reduced, because we know there is splenomegaly in chronic liver disease, and that spleen causes sequestration and destruction of platelets from the blood. So number of platelet in the blood is reduced. So and moreover, the liver itself cannot produce the coagulation factors. We know much of the coagulation factors are produced from the liver, but here the diseased liver cannot produce the coagulation factors. So there is hemorrhagic tendency, and there is easy bruising, there is purpuric spots, and the patient may complain of recurrent epistaxis. Constructional apraxia, yes, this is a test. Normally it is done to find out whether the patient has got hepatic encephalopathy. Constructional apraxia stands for inability to perform a known act. Inability to perform a known act. That is, if you draw a star and ask your patient to please draw the star, the patient will not be able to draw it accurately. Or you can draw a clock and ask him to draw a clock, he will not be able to draw it accurately. This is constructional apraxia, signifies hepatic encephalopathy. And this is a number connection test. Number connection test. That is, there are 25 circles containing a digit in each of the circle, starting from 1 to 25. If you ask a normal person to connect the circle with each other, keeping the sequence 1, 2, 3, 4 intact, a normal person will be able to do it within 30 seconds. But in case of hepatic encephalopathy, the person will not be able to connect it so quickly. Furthermore, he will not be able to maintain the sequence as well. So these are the physical findings, as well as these are the tests that we'll do to diagnose a case of chronic liver disease. And all these features will suggest the presence of chronic liver disease and its complications. Now, to confirm your clinical judgment, what you have thought by the history, physical examination, you have got some provisional diagnosis. From that, if you want to confirm your diagnosis, you need to take the help of the investigations. So we'll go for CBC. We'll go for complete blood count, and there might be anemia, because this is a chronic disease. The patient may develop anemia of chronic disease. The patients of cirrhosis are reluctant to take food, so there may be nutritional anemia. Moreover, in chronic liver disease, sometimes patients develop esophageal varix, which may bleed and giving rise to anemia. So hemoglobin level is very important, and you will find that the ESR is also high. Then you go for liver function test, you will find that the alanine aminotransferase is high, serum bilirubin is elevated, serum albumin is low, because we know the albumin is produced by the liver in our body. A diseased liver cannot produce albumin, so albumin level will be low, and albumin globulin ratio will be altered. Normally in our body, albumin is more and globulin is less, but in cirrhosis of liver, you will find that the ratio is altered. Globulin is more and albumin is less. And prothrombin time will be prolonged, because activation of prothrombin depends on coagulation factor 1, 2, 5, 7, and 10. And these factors are produced by the liver. So here, as the liver is not producing those factors, the prothrombin time will be prolonged. Then you will search for the cause, why the patient has developed cirrhosis of liver. So the commonest cause is viral hepatitis, and we will look for whether the patient has got viral hepatitis. So we'll go for HBsAg to see the hepatitis B viral infection, and anti-HCV to see whether there is hepatitis C viral infection, because we know these two viruses can cause chronic liver disease. Then you go for ultrasonography of hepatobiliary system, which will give a lot of information. Like ultrasonography will say that the liver is coarse in parenchyma, it is shrunken, smaller in size. Ultrasound also will say that there is splenomegaly, and if there is an ascites, ultrasound can also mention that. So ultrasound will give you a lot of important information. Then we'll proceed to endoscopy of upper GIT. Endoscopy of upper GIT to see whether the patient has got esophageal varix, which is a complication of chronic liver disease. There may be esophageal varix or gastric fundal varix. So if you get the varix during endoscopy, it will confirm that there is portal hypertension. The next investigation of choice is fibroscan of liver. Fibroscan of liver is a test that is done to see the stiffness of the liver, because we know in cirrhosis of liver the liver is fibrous, so the stiffness of the liver is increased. So it can be detected with the help of fibroscan of liver. And liver biopsy is the confirmatory test, though it is rarely done. Why rarely done? Because we know that in cirrhosis of liver, the patient has got coagulation defect. So if you go for liver biopsy, it can cause internal bleeding. But so it is not done, and all other investigation is adequate to diagnose a case of chronic liver disease. It is done only in doubtful cases. The next important investigation is ascites, ascitic fluid study. Ascitic fluid study. We know that depending on the protein content, there are two types of ascites, like transudative ascites and exudative ascites. And in case of chronic liver disease, we'll get, in most of the cases, transudative ascites, where the protein content is less than 2.5 gram per deciliter. But it is true for 70% cases. In 30% cases, you will see that the protein content is more than 2.5 gram per deciliter, which will confuse you to reach to the diagnosis. So to confirm that this ascites is due to portal hypertension from cirrhosis of liver, we do SAG. SAG stands for serum ascitic fluid albumin gradient. So at the same time, we draw the ascitic fluid and the serum from the patient and send it to the lab to see the albumin level. And then we deduct the ascitic fluid albumin level from the serum albumin level. After this subtraction, if the result is more than 1.1 gram per deciliter, then this ascites is due to portal hypertension. And if it is less than 1.1 gram per deciliter, then you have to think for other causes. And this SEG is 96% sensitive and specific. So this is very sensitive and very specific to diagnose and to confirm that this ascites is due to portal hypertension and due to cirrhosis of liver. There are some special investigations that are not done in all patients, only in suspected cases. Like if you suspect that this person has got autoimmune hepatitis, then you can go for anti-nuclear antibody and anti-smooth muscle antibody. On the other hand, if you suspect this patient has got primary biliary cirrhosis, then you can go for anti-mitochondrial antibody. These are special tests I mentioned, not done in all cases, only in suspected cases. Suppose if you suspect that this patient has got hemochromatosis, then what will you do? You will go for serum iron and serum ferritin level. And in case of Wilson's disease, you will go for serum copper, cellulose plasmin, and 24 hours total urinary copper level. Because we know in hemochromatosis there is iron overload, and in Wilson's disease there is copper overload. Now let us just see what are the complications that may develop in cirrhosis of liver. Yes, the commonest one is ascites. Ascites, that is accumulation of fluid abnormal amount of fluid in the peritoneal cavity that occurs in cirrhosis of liver. The next one is esophageal varix. Esophageal varix develop due to portal hypertension, and the varix are present in lower end of the esophagus, furnace of the stomach, even sometimes in the rectum. So varix is another complication. Person may develop hepatic encephalopathy, where the cerebrum has not any intrinsic disease. The brain has not any intrinsic disease, but it is unable to perform the normal activity due to hepatic failure. The next one is spontaneous bacterial peritonitis. The name itself says this is spontaneous, and it is a bacterial peritonitis. It is called so because here the source of the bacteria cannot be identified. From where the bacteria has come to infect the peritoneum could not be identified. So this is spontaneous bacterial peritonitis. The other two are hepatorenal syndrome and hepatopulmonary syndrome. Here there is renal and pulmonary dysfunction due to liver failure, where there is no intrinsic disease in kidney or lungs. It is due to liver failure. And some patients of chronic liver disease who have cirrhosis of liver, in course of time they develop malignancy, and this is hepatocellular carcinoma. So these are the complications of chronic liver disease. We know that most of the complications of chronic liver disease or cirrhosis of liver are due to portal hypertension. Portal hypertension ultimately giving rise to those complications. A normal portal pressure is 2 to 5 millimeter of mercury. When it becomes more than 12 millimeter of mercury, in that case, gradually the complications of portal hypertension develops. See in this picture, this is a normal liver with normal architecture. Blood is passing from the portal vein smoothly through the hepatic sinusoids. Then it is going to hepatic vein without any resistance. So this is the normal function of a normal individual. But what happens in cirrhosis of liver, there is nodular regeneration and fibrosis of the liver. So it is there is architectural destruction of the sinusoids. So blood cannot pass easily through that sinusoid from the portal vein to the hepatic vein. There is huge resistance at the level of the sinusoids, giving rise to rise in the portal pressure. And this is how portal hypertension develops and subsequently giving other complications. So what are the features of portal hypertension? The features of portal hypertension are splenomegaly, ascites, varix, and hepatic encephalopathy. Sometimes you are asked, what are the features of portal hypertension? And your answer will be splenomegaly, ascites, varix, and hepatic encephalopathy. This is a very important issue. How you are going to manage a case of cirrhotic ascites? When you will become a doctor, obviously very soon, when you will do your duty in the ward, you will find that each and every day you will have to manage a case of cirrhotic ascites, maybe in medicine ward or maybe in the ward of gastroenterology. This is so common in our community. So this is very important issue for us. We will start with bed rest. We will start the management with bed rest, because when the patient is taking rest in his bed, the renal perfusion increases. And when renal perfusion increases, it increases the GFR, increases the urine output. So this is how the extra fluid from the body is excreted, and it improves the ascites. Then you will go for salt restriction. Salt restriction, yes, you will not advise that the patient should not have salt in his cooked food. He will have salt in his cooked food, normal salt in cooked food, but he will not add any added salt in his plate. So 100 ml per day salt can be taken orally. Ask him not to add any added salt in his plate during meal. Then advise the patient to avoid drugs that containing large amount of sodium, like NSAIDs, like antacids. Then what about water restriction? Are you going to advise for water restriction? Yes, you will advise for water restriction, but when the plasma sodium level falls at 125 millimole per liter. Water restriction becomes necessary when plasma sodium falls below 125 millimole per liter, and normally we advise for 1 to 1.5 liter of water per day, and we strictly maintain the intake output chart. You will find that many patients with just taking rest and salt water restriction will improve, but some will not. In that cases, you will need the help of some drugs. They are the diuretics. And for ascites in cirrhosis of liver, the diuretics of choice is spironolactone. You will add spironolactone and gradually increase the dose. But if you see that the spironolactone alone is unable to reduce the ascites in this patient, then you can add another diuretic, and that is loop diuretic, that is furosemide. So in most of the cases, with the help of spironolactone and furosemide, the ascites will improve. But even then, you'll find some patient who will not completely improve. So you will have to search for the cause. Why the patient is not improving even after using those diuretics, and you will find the cause. Like it may be a cause of hypoalbuminemia. So you have to correct the albumin first. It may be a case of spontaneous bacterial peritonitis. So you treat the peritonitis first. Otherwise, the ascites will not improve adequately. When you will find that after the maximum dose of spironolactone and the maximum dose of furosemide, still the patient has got ascites, he is not improving to the satisfactory level, then this is a case of refractory or diuretic resistant ascites. In such cases, the patient may need recurrent paracentesis, maybe weekly, maybe fortnightly, but he will require recurrent paracentesis or aspiration of ascitic fluid. There are some other modalities, though rarely used. They are TIPS. TIPS stand for transjugular, intrahepatic, portosystemic stent shunt. Transjugular, intrahepatic, portosystemic stent shunt. Here a stent is placed between the portal vein and the hepatic vein. So the blood can easily pass from the portal vein to the hepatic vein. The other one is peritoneal venous shunt. This is a surgery, and the ultimate answer is liver transplantation. But these are actually rarely done. Most of the cases are managed with the help of the general advice like bed rest, salt water restriction, and together with the help of the diuretics. So let's read this story. A 30 years old male presented with history of jaundice. He has abdominal and leg swelling for last 2 years. Now he developed profuse blood mixed vomitus and black tarry stool. On examination, he is anemic, he is icteric, he has tachycardia, edema, ascites, and other features of chronic liver disease. What can be the cause of this bleeding? So I am confident enough that you are thinking about bleeding from ruptured esophageal varix. Yes, this might be a case of bleeding from ruptured esophageal varix, where the patient has got the feature of chronic liver disease and physical findings of chronic liver disease, and this time presented with blood mixed vomitus. Most likely diagnosis is ruptured esophageal varix. Now, how to confirm the diagnosis and how to manage the case? As the patient has got history of hematemesis and melena, he has got the features of chronic liver disease. So it is in our mind that this is a case of chronic liver disease. We confirmed it with the help of ultrasonography. Ultrasonography told that there is shrunken liver, splenomegaly, and ascites. Now, to confirm the cause of bleeding, we have to go for endoscopy of upper GIT, because the endoscopy will locate the bleeding vessel, as well as endoscopy can give treatment to stop the bleeding during endoscopy. So if we want to summarize the management of a case of variceal bleeding, because this is very important. Suppose on fine evening you are on duty in your ward, suddenly a patient of chronic liver disease came to you with profuse upper GI bleeding, you may become tense if the modalities of treatment is not uh, conditioned in your brain. You should be conditioned, you should be preoccupied. What are the things you need to do in that emergency? If you are preoccupied with what are the things you need to do in that emergency, it is not a matter for you. You can easily manage it. So we'll go for resuscitation first. In such scenario, we'll not go for a detailed history first, because if we start a detailed history in a patient of acute upper GI bleeding, we may take a good history, but the patient will expire. So we'll have to resuscitate first. So check the ABC, check airway, whether the airway is clear, whether the breathing is spontaneous, whether the circulation is intact, palpate the pulse, even including the peripheral pulses, and measure the blood pressure, whether these are okay. Then open to IV channel. You open to IV channel and send blood for blood grouping and cross matching. At the same time, you start IV fluid with crystalloid. Crystalloid fluid will maintain the intravascular volume and maintain the blood pressure. And when the blood is available, if indicated, you can start blood transfusion. Platelet transfusion is not always necessary, but if a patient with cirrhosis of liver with active bleeding having a platelet count less than 50%, you can go for platelet transfusion. And if there is prolonged prothrombin time, then you have to give fresh frozen plasma. There are some drugs which can reduce the portal pressure, and that can stop varicose bleeding by reducing the portal pressure. So, and there the vasopressin, terlipressin, somatostatin, and octreotide. But the ultimate treatment is endoscopic therapy, that is band ligation and sclerotherapy. We used to put band at the bleeding vessel, thereby it stops its bleeding, and we can also give sclerosant agent injection into the bleeding vessel to coagulate the blood vessel. If you look into this picture, you can see that there is esophageal varix. Here the columns of varix. Here in the middle one there is active bleeding, and this one after giving the band ligation treatment, the bleeding has stopped and all vessels has collapsed after giving the bands on the varices. There are some prophylaxis, primary prophylaxis. These are given prior to the development of fast bleeding. If you can diagnose this patient has got esophageal varix, but there is no history of variceal bleeding, you can start some drug that will reduce the portal pressure, and thereby it will prevent the primary bleeding. The drugs used are propranolol, nitrates. Most of the time propranolol is used, but when propranolol is contraindicated, like if the patient has got bronchial asthma also, you cannot use propranolol, then you can give nitrates. And endoscopic band ligation can also be used as a case of primary prophylaxis prior to the development of fast bleeding. This is another story. A 45 years old male presented with drowsiness, confusion, disorientation, slurring of speech. And he has got jaundice, he has got flapping tremor, edema, spider nevi, and ascites, suggesting chronic liver disease. So a person with chronic liver disease presented with altered mental function. So what will be our diagnosis? What could be the cause of impaired mental state? I'm sure you are thinking about hepatic encephalopathy. Hepatic encephalopathy, where the brain itself has no intrinsic disease but unable to perform due to hepatic failure. Here you will find that there is disturbance in brain function provoked by circulating neurotoxins. There are some circulating neurotoxins that are disturbing the brain function. Normally in our body, these neurotoxins are also produced, but our liver can detoxify all those neurotoxins. But in a case of cirrhosis of liver, a cirrhotic liver cannot detoxify those neurotoxins. So this blood goes to the brain and causing hepatic encephalopathy. There are a lot of neurotoxins, but the commonest one is ammonia. This ammonia is produced in the gut by the fermentation of nitrogenous substance, especially protein, by the bacteria. Bacteria produces ammonia by the fermentation of protein. That ammonia is absorbed in the portal circulation in the form of ammonia. It goes to the liver. A normal liver detoxifies the ammonia, but a cirrhotic liver cannot detoxify. So the ammonia together with the blood goes to the brain and causes the features of hepatic encephalopathy. And how to manage a case of hepatic encephalopathy. If you can identify the precipitating factors, you have to treat the precipitating factors, like sometimes rich protein diet or constipation or any infection in the body, dehydration, electrolyte imbalance, and so on. We have discussed the precipitating factors in our lecture class. So, if you identify the precipitating factors, you have to treat it. This will improve encephalopathy. And treat the underlying cause. Suppose the patient has developed cirrhosis of liver due to hepatitis B virus infection. So you treat the hepatitis B. If it is due to alcohol consumption, to stop alcohol consumption. If it is due to any drug, stop taking that drug. So identify and treat the underlying cause. Then you give low protein diet. Why low protein diet? Because we mentioned that the ammonia is produced in our gut due to fermentation of the protein content. So if you give low protein diet, it will reduce the protein content it will reduce the ammonia production, and thereby it will improve the encephalopathy. We'll give some gut sterilizer because we know that the ammonia is produced by the bacterial fermentation of protein. So if you give some gut sterilizer in the form of antibiotic, if you can reduce the number of bacteria, it will reduce the production of ammonia as well. So we give metronidazole, rifaximin, or neomycin. Neomycin nowadays is less used due to its price is high, as well as it has got some side effects. So we use more in our world metronidazole and rifaximin. You will give some osmotic laxative. Your intention is you have to there should be 2 to 3 motion every day. The patient should pass feces for 2 to 3 times every day, so that the bacteria do not get enough time to produce ammonia. And the lactulose also reduces the pH of the gut, thereby it reduces the bacterial proliferation. So we give osmotic laxative, lactulose. No sedative and diuretic should be used. These are contraindicated in a case of hepatic encephalopathy. And liver transplantation, actually, it is the ultimate management. If a patient goes for liver transplantation, after a successful transplantation, there will not be any hepatic encephalopathy. So this is the last story today. This is the last story today, where a known case of decompensated cirrhosis of liver presented to you with fever and abdominal pain. On examination, you found the body temperature is raised and he has ascites and rebound tenderness and bowel sound absent. So patient with cirrhosis, decompensated cirrhosis, who has got ascites, came to you with pain, abdominal pain and fever, and you examined the patient, found there is rebound tenderness and absent bowel sound. So what is your diagnosis? Yes, your diagnosis is spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. It is a complication of decompensated cirrhosis of liver. But how to confirm your diagnosis? Diagnosis always starts from history. This patient has got history of chronic liver disease, followed by physical examination. You could elicit that there is ascites and abdominal tenderness, as well as absent of bowel sound. Now, to confirm your diagnosis, you will take the help of investigation. So you go for ascitic fluid study. If you do the ascitic fluid study, you will see that morphologically the ascitic fluid is cloudy. It is cloudy. It is not clear. It is cloudy, suggesting that there are infection in the ascitic fluid. And if you go for WBC count, it is more than 500 per cubic millimeter of fluid. And if you go for neutrophil count, it is more than 250 per cubic millimeter of fluid. Then if you send the fluid for gram stain, you will get, in most of the cases, you will get a gram negative organism, mostly E. coli, and send it for culture. So you will get the culture of bacterial growth in the culture, as well as you will get the most sensitive antibiotic to treat the patient. How to treat a case of spontaneous bacterial peritonitis? We use broad spectrum antibiotic. At first, we draw the fluid, send it for gram stain and culture. At the same time, we start a broad spectrum antibiotic. And when the culture report is available, then we see whether the antibiotic that we are using is sensitive. If not, we can even shift the antibiotic. In most of the time, we start with a broad spectrum antibiotic such as cefotaxime or piperacillin and tazobactam. Sometimes you'll find that the bacterial peritonitis has become recurrent. A patient time and again suffering from spontaneous bacterial peritonitis. In such cases, you have to give some prophylactic antibiotics like quinolones. It is the most commonly used antibiotic as a prophylaxis for recurrent spontaneous bacterial peritonitis. And ciprofloxacin and norfloxacin are very much known to us. Their quinolones are used as a antibiotic for recurrent spontaneous bacterial peritonitis. And dear students, thank you so much for your patience hearing. Uh, Nice to meet you again after a quite long time. Hope very soon you'll become doctors, and with your knowledge and with your good intention, lot of cirrhotic patients will get proper treatment and they will be able to survive longer. Stay blessed, stay safe. We are praying for you. Pray for us also. We are missing you a lot, and hope the Almighty will help us. And very soon we'll be meet again in our Jalalabad Ragib-Rabeya Medical College campus. Thank you so much. Thank you all.